Since it's what's keeping you from the weekend, traveling back or from enjoying the city, here my disclosure slide. As you've seen in other talks, I want to use a case of a patient to kind of go along certain lines of thought in exploring dialysis access. So we're starting out with an 81-year-old lady who has a new access created in December 2008. She had a previous access that failed after 10 years after many revisions. So this is the angiogram. At the bottom, you can see the brachial artery, and then at the left side of the screen, you have the anastomosis, and then the cephalic vein that arches as a black line to the top with the cephalic arch and then the central veins. So I can see that there are some irregularities in the angiogram, but by and large, this is a patent access. You can see some valves there, some side branches, but the question is, she has an autogenous access created. This is the initial angiogram. Here are four options. Is this type of access problem-free? Is there actually the reverse true, 60% chance of failure that this will not mature? Is there typically an inflow stenosis in this type of upper arm access, or is steel not a problem with this access, or can it develop a problem over time? So we'll go through these bit by bit. Let's look at this first one. This access is usually problem-free. And we could do a show of hands if you think it is. The reality in this access is that over time, we're going from this initial angiogram to this angiogram where you can see a dilated segment where the needles are placed in the body of the access. And then you have this kind of strung out thin vein towards the shoulder with a cephalic arch where the trained eye may discover that there's a stent graft there. So this access has been characterized by recurrent stenosis of the cephalic arch, very typical for this type of access. Eventually a stent graft was placed, but the vein at that point is so diseased, has been exposed to thrombus, and then has a recurrent inward remodeling and stenosis. And this access basically has chronic access disease, and it's a different chronic disease for each type of access depending on its anatomic location. Eventually this access needed another stent graft and then lasted until the lady died, but a lot of work has to be invested. So chronic access disease relates to pre-programmed sites of stenosis that, depending on the access in a graft at the venous anastomosis, cephalic arch, upper arm brachiocephalic vein fistula, at the basilic swing point, and sometimes at sites of surgical intervention, side branch ligations for forearm accesses. There is a continuous increase in flow as the artery increases in response to increased shear stress by dilating to lower the shear stress. That then increases the flow in the circuit, and unless there is a permanent stenosis, the flow will rise to substantial diameters and through the increased flow cause pathologies. Exposure of thrombus, we talked about. Chronic scarring. Angioplasty itself is not benign. There are clear studies that show that if you expose particularly central veins to balloon angioplasty without a good reason, you get faster progression and recurrence of the stenosis if you didn't put a balloon in. If we use foreign material like stents or stent grafts, they have a different flexibility than blood vessels, and so often we see edge phenomena where there's turbulent flow and there's debris building up over time. So if you place a stent graft, you manage an outflow stenosis that you can then recanalize easily, but you know that you have to come back a couple times per year. Needle insertions, especially if they're focal and not moving along the access, can also lead to dilatation, or they can enhance dilatation of accesses. They can also lead to skin degradation, and the needle tip, if it's always placed at the same time, can form a stenosis. So is there a 60% chance that this type of access will not mature? Well, if you look at all accesses that are created, then there are some that will progress along the green line. Flow goes up and they go into a range where they're used, or they go to this red line where there's some flow, but then something happens and they kind of meander along, and they're really never usable unless you do something. And then there's a third group where there's some flow initially or very shortly, and then they go away. And it turns out that in the largest randomized controlled study that was performed by DEMBA, the Dialysis Access Consortium fistula study in 2008, that 63% of fistulas never got to that green line. They're all in that red and blue zone, which is the area where if you have an active program of monitoring and intervention, you can get a lot of these accesses, over 90%, to actually use. So you can move you can work hard on the 60%, get many of them to use, and of a large fraction, 70% almost, are still in use at 1 year in time. And it probably depends on your quality of follow-up and what kind of interventions you do, how close the surgeons and interventionists work together, how many you can keep alive. It's pretty clear that a good surgeon is worth a lot. So in that study, the DEMBA study, on average, the surgeons did something like 3 fistulas per year. They certainly did a couple more, but the assumption is that they tried to get as many into the study as possible. It is probably true that if you want a good access surgeon, you have to have like 100 plus fistulas created by that person per year. Maybe not for the entire time of that surgeon, but for some time so that they gain experience. If you don't have that, you need to try to build that. Here's an example how endovascular work can help in the situation when you have that small diseased vein. So here you see upper arm brachiocephalic vein fistula. On the right hand side is the anastomosis. On the left hand side, the cephalic arch. And you can see that there are a couple of focal stenoses in the inflow. What we then do is we carefully increase the flow in the access with multiple angioplasties, give time in between. And you can see here, first day they come, we use a small balloon, 4 millimeter, bring them back 2 or 3 weeks later. There's partial recurrence of the stenosis. Other parts of the access have now dilated. The vein also dilates and remodels under shear stress. And so we repeat the angioplasty, and then after about 2 months after surgery, 40 days after the first angioplasty, you now have an access that clearly has increased the venous diameter 2 or 3-fold in comparison to the first image, and then is usable for needle insertion. In fact, now 10 years later is still in use with a cephalic arch stent graft, but very, very little maintenance. What makes a good access? We can now ponder if fistulas have so many issues. You want to have an inflow and an outflow. Inflow provides enough blood, outflow that allows the blood to come back to the heart without increased venous pressure so that there's no arm edema. And you need to have a sufficient stick zone for the needles so that you have the ability to insert needles over a prolonged period of time without losing the skin integrity. Safe repeated needle insertion and removal. The blood flow rate needs to be higher than the blood pump speed that you use in your setting. In the US, that may be 500 blood pump speed in some scenarios, while if you go to China, a lot of people dialyze with 250 ml per minute. And so you can do with lower blood flows. You do longer dialysis treatment times. So this is a relative statement. You don't want to have steel, and you want to have intra-access pressures, and we come back to that are conducive to long-term integrity of the skin. So here is I don't know, is there a sound button or the sound plug-in? No, we do it like this, yeah. So this is the historic experience of the Brescia Semino fistula. And so you can hear, continuous flow murmur, a little bit stronger with systole. And that works well because you have multiple outflow veins. You can see there's at the elbow, there's brachial veins, bacillic veins, cephalic veins, low pressure in the access. You see here the effect of 20 plus years of needle insertions. Yes, there are enlarged needle insertion sites because most arms hang down all the time. And just by hydrostatic pressure, there's a little bit distension after needle insertion. But the skin is completely intact, still well pigmented. This is a good access. What happens when you have a forearm radiocephalic without multiple outflow veins at the elbow is depicted here. It's a radiocephalic fistula 2004 that within 5 years develops very quick degeneration of skin, more aneurysms, depigmentation, scabbing, etc. because the pressure in the axis is basically dependent on the smallest diameter in the entire axis. You're probably all familiar with this graph. There has been with fistula first and then catheter last, a lot of effort to bring America to what the rest of the world has been doing, higher fistula prevalence rates. And we've gotten there. We have 60% plus fistulas now. We have less than 10%, I think newest numbers 9 point something percent long-term catheters. And that's good. But if you look what type of fistulas we are creating, they're different from the ones that we initially used and that are used in many other parts of the world. So random dialysis unit, just looking at where are the axes located, forearm versus upper arm. And 2/3 are in the upper arm and only 1/3 is in the forearm. If you look at the large trials, randomized controlled trials that were performed with participation across the United States, the DAC study and then the HFM study 10 years later, you can see how the prevalence of choice of where the accesses go has changed. It goes from 50%, near 50% in the DAC study to 24% in the HFM study. And that may be patterns that you're familiar with at your local institutions. Contrary, the brachycephalic vein fistulas have increased, and even more so brachybasilic vein fistulas. Yeah? So the forearm fistula is kind of a vanishing entity. However, yes, we get more autogenous accesses. They are in older people, so maybe that's a driver for that. It's partially also that surgeons want to have success and they don't want to futz around with the forearm access where it's difficult. And so you get more upper arm accesses where the vein is typically a single tube from the anastomosis to the central vein. So if there's any issue, the pressure is elevated. And you all have noticed that upper arm accesses, by and large, have way more needle insertion site aneurysms than forearm fistulas. They get bigger faster, and the skin gets thinner faster. There are more bleeding events. And the flows are higher. Yeah? Now, to the question, does this type of access, brachycephalic vein fistula, has typically an inflow stenosis? No, the typical stenosis, as you have seen in many slides, is the cephalic arch inflow stenosis. There are some that have cephalic arch outflow stenosis. There are some that have an inflow stenosis, but predominantly upper arm brachycephalic vein fistulas have an outflow cephalic arch stenosis. These are the locations for graft. We know it's the venous anastomosis. The forearm, that's where it's typically, in order to get maturation and get flow rates that we in the United States need, we have to treat all the juxtaanastomotic stenoses that are there. In other countries, that's not that necessary because you can be fine with 200-300 flow. And then obviously the transposed vein fistulas at the swing point. Here's a graphical depiction of this. On the left side of the forearm axis, 50% of stenoses on average are located juxtaanastomotic or at the inflow, while in the upper arm brachycephalic, it's 55, 50, 60% cephalic arch. And cephalic arch stenoses come back rapidly every 3 months. It's a very good investment for the interventionalist, but they also lead to loss of access when you cannot recanalize them anymore. You have to put a stent before that happens. While juxtaanastomotic stenoses, they come back sometimes on a much slower time scale, and the signs of failure are decreased clearance versus thrombosis, bleeding, and aneurysm formation. For grafts, about 2/3 are in the anastomosis, or venous immediate outflow vein. And what this brings home is that if you know that your accesses have recurrent stenosis at the same point in time, how can you, in the same location, how can you detect it? What is the cheapest, what's the most reliable way to do it? We've tried all kinds of techniques, but it turns out that physical exam in expert hands, in trained hands, is as good or better than any technology that you may apply. We locally tried that. We asked people who take care of the patient in the unit, is your access normal or not? And purple is the purple is normal and red is abnormal. If you then have an expert exam juxtaposed, same access, you have a lot more abnormal accesses that you can then angiographically examine, and you can then normalize the physiologic factors by flow measurements as well as pressures. So the question is always, does the nephrologist in the dialysis unit have no time or no expertise, or they just can't get to the access with all the tape in place? In case for you all, it's just the lack of time and you kind of know what to do, but I just want to walk through what are the 5 elements in the access exam that I think you should take home and be able to integrate into your clinical practice. And in the workshop, we'll kind of, as Dr. Vokulescu mentioned, we'll go over this a little bit. It's pulsatility, thrill, augmentation, flow murmur, bruit, and the collapse of the access with gravity. And briefly, the pulsatility is how strong a pulse you feel in relation to blood pressure. And so it's kind of an expectation that you have to set. It's not something where you feel and, oh yeah, this is what it is. You have to kind of teach your fingers a certain pressure. And I have a film here that documents that visually too much pressure. So this is a forearm loop graft, but you can see how it jumps at you, right? With each, that is too much pressure. We have measured it. I mean, normal access pressures, we like them to be between 25 and 35 millimeter mercury inside the access. You can actually measure pressures, static pressures on the dialysis machine. It's a little bit, it's a protocol that is not that simple, but it allows you to kind of get, if you have a question, well, is the pressure high? Is that why my aneurysms go so large? That you can get that. This is an access where the concept of augmentation, I want to explain, it's the crucial quality of an access that allows needle insertion. So in this case, it's a brachycephalic vein fistula that has outflow to the cephalic arch on the left, but at the same time a large side branch to the forearm. So when the nurses use a tourniquet at the shoulder level, all the blood dissipates towards the forearm. So the vessel remains flaccid. So he has recurrent needle infiltrations because the needles just go through and through. Either ligation of the access or a second tourniquet, distal, will remedy this and will allow the access to augment. Here is another upper arm brachycephalic vein fistula. You can see the incision there. There's increased pulsatility at the anastomosis, but then a thrill right afterwards. There's diminished augmentation and a discontinuous flow murmur. So this is a typical constellation of a juxta-anastomotic stenosis. And what you can hear there is kind of this, it's not a continuous flow murmur. It has this strong, harsh component, then almost stops and then continues. Yeah? So I'll repeat that. Here's the angiogram. You can see the stenosis right after the artery where the red arrow is. And I'll play the sound again. You can see flows 400. The vessel has a moderate diameter. We do an angioplasty and get the patient back a few weeks later. And you see the angiogram shows that under the right flow, the vein is immediately larger, the flow is 3 times higher. Now listen to this. So this is much more like wave-like flow on the beach. It doesn't stop. Yeah? So this is what you want to find. If you get the other pattern, well, then you have to figure out, do you want to intervene? Where do you send the patient? What's the timing after surgery? The final point in the physical exam is the balance of inflow and outflow, the collapsibility of the access. So here you see a forearm access that is very nicely distended. It has been used for many, many years. And there are no aneurysms, basically, right? I mean, it's just continually slightly larger. Huh? And if the patient lifts the arm, you get complete collapse of the access. So the pressure in this access at all times is very low. If you have an upper arm access, very rarely, almost only in the setting of an inflow stenosis, will you get complete collapse. You get partial collapse, but rarely complete collapse because the flows are much higher and the outflow is more difficult. It's through the cephalic arch or the basallic swing point. This is, I think you have that in the online handout, just a composition of what type of access will you combine with what kind of physical exam with these 5 qualities in the setting of a typical stenosis. Here similarly is a table of the physical exam during maturation where the findings are there in dependency on what is the element that may be interfering with maturation. And this brings us to the last point in our question. We've all heard about steel. How does steel relate to upper arm accesses? So here's another case with an upper arm brachiocephalic vein fistula, 1400 flow, which is a typical access flow for an upper arm access. Patient presents with these punctate ulcers on the fingers. And you can see angiographically in the left upper corner, the catheter is at the bottom in the artery. Contrast is injected and goes completely, seemingly, into the access. When the access is occluded, which is the lower picture, only then contrast that is injected into the brachial artery moves forward, integrate into the ulnar, interosseous, and radial arteries. So the entire blood flow that goes to the hand is through small collaterals that travel parallel to the brachial artery because brachial artery blood flow completely goes into the fistula. In order to treat this, you can use a technique that's called banding. Can be done in an outpatient center often, where you make an incision across the access, you isolate the inflow vein, you bring a suture around it, and then over a spacer, you tie a suture that narrows the inflow and creates a stenosis. Yeah, you can see that here, access open, access occluded, and then we've added 2 bands into that inflow segment, increasing the resistance in the access, and now contrast is injected without occlusion of the access, and you can see antegrade flow in the radial and ulnar artery. Yeah? So this is something that if you have upper arm accesses in your dialysis patient population, you'll have all the time. It's a very frequent thing. Diabetes, hypertension are very prevalent in our patients, and so is the predisposition for steel. An alternative approach surgically is, instead of going to the brachial artery, is to hook up the cephalic vein to the proximal radial artery. That leaves the ulnar artery blood flow to the hand. So that is an endogenous way of how the surgeon can prevent this, prevent steel, and that works. But it means that you need a little bit longer length and a slightly different surgical technique. Other things that can happen with access flows. Now here's a forearm access created with 1300 flow in an 84-year-old gentleman. Great artery, great flow. The problem in him was that within 6 months he developed dilatative cardiomyopathy from the high output failure that this access was giving him. So patients differ in their tolerance, and here you have something that's almost like a whole body steal, where the access just takes too much blood away from the body. Just to fit it in at this point, sometimes you have small arteries, and we often advocate to go to the forearm If you have a highly calcified artery, like in this patient with very low flow that is too low for dialysis use in the US setting, you can dilate the artery, and you can get away with this because you're working in the radial artery and the hand is perfused by the ulnar artery, and we have separated the ulnar, the connection between the radial artery and the palmar arch, so that you have a very long pressure head between the two flow beds. And so you can get then actually in somebody with very calcified arteries still to flows nearly of 1,000 ml per minute, and can do sufficient dialysis over many years without steel. And that works very well in a forearm access because you have that natural division between ulnar and radial circulation. You have to obviously make sure that the palmar arch is continuous so that the entire hand can be perfused from one of the two arteries. Now, we're very flow focused, but a lot of the issues in dialysis are actually related to pressure events. So bleeding after needle removal, enlarging inertial site, skin thinning, layered thrombus formation, those are all pressure related events. And here is just a sequence of 4 images of a patient over the course of 5 years, where in the setting of recurrent cephalic arch stenosis, you can see these needle insertion site aneurysms grow rapidly. Yeah? He's elderly gentleman, thin skin, and you can see the intra-access pressures that we measure there. Prior to angioplasty, the mean pressures are 64, the post pressures are 49. We like to get them to 35, and in those cases we then band and reduce the flow. If you don't take care of this, the skin will become damaged and you get scabs, and then at some point you get rupture, which can be terminal or not. If you have chronically elevated pressure, and this is something interesting, if you have a dysfunctional access that's not used in a transplant patient, for instance, like in this case, you can actually get calcification of the entire vessel, which it's a neat picture. The access was not usable in this form because it has lost all its elasticity, and when the needles are placed, it's really crunching through rocks. And so it had to be replaced. But just to show how the effect of chronic pressure can have an effect on the blood vessels. How are pressure and flow related? Here's an upper arm access. You can see needle insertion sites with slight dilation. When I occlude the inflow, the whole thing collapses. Yeah? That's in the setting of no stenosis. If this access presents intermittently with a stenosis in the outflow vein, where then blood is shifted to this parallel pathway, and the blood flow rate is 1,300 with a blood pressure of 193/90. Increased pulsatility, no collapse of the access. The intra-access pressure at this time is arterial, 92. Yeah? After treatment of the stenosis, you can see how the collateral flow is relieved. The flow is only minimally increased. You would have thought that the flow goes up, but it turns out when you look at the little blue arrow on the side, there's an inflow stenosis that acts like a banding. It limits the maximal flow. And in that setting, with a limit on the inflow, the intra-access pressures drop down to 29. So this access is super soft, the skin is completely intact. Yeah, you can put needles in there for years and years to come. Similarly, if you have an upper arm access like here with an inflow stenosis, even after years of use, no aneurysms. Yeah? And the sign of failure that it presents with is usually hematomas when the inflow stenosis becomes so tight that the flow drops, and with the tourniquet there's not enough augmentation anymore to safely place the needles. So we measure pressures. This is what I pointed out before. If you create a fistula with a large anastomosis, you can get giant fistulas. Yeah? 10-year transplant, never use the fistula, 4 liters of flow, and then you have to do very involved surgeries to get the aneurysm smaller, to band the access, but you can reconstruct autogenous accesses very, very flexibly. So you can see that here, on top is before, bottom is after a very heroic intervention, I think 4 surgeries, but there's an obvious side effect of reducing the cardiac output, which I think has the key consequence for the long-term survival of these patients. Again, an example of outflow and inflow control. I just have the last 6 minutes. I want to briefly spend on tunneled catheters, as I think we still have a very high rate of tunneled catheter initiations. So it's good to have some thoughts about this. So you see this photo here, there's some discharge from the exit site. Does this catheter have to come out or not? Is this something you can treat with antibiotics? As long as the tunnel is not affected, then this is a treatable condition. You need exit site care, you need antibiotics, but largely these clear. So here are our options, and we're going to again go through them. IV antibiotics, local exit site care, exchange of catheter, create new exit site, or lock solution. So let's talk about, for exit site infection, this is what you can do. Yeah? The cuff is right there. The cuff represents a seal between the skin flora that is inside the exit site and the sterile tunnel and the inside of the blood vessel. Exchanges of catheter over guide wire, as the tunnel is infected. If you have a tunnel infection, you never want to, this is basically, it's an empyema, and you don't want to put any new plastic through an empyema. So here we have a patient that presents differently than the first patient. There's mental status changes. There is some erythema overlying the tunnel tract. And if you then do this little massage swoop towards the exit site, you can harvest the copious amounts of purulent material. Tunnel infections, catheter has to be removed, and you have to either go to the other side or create a new tunnel. Lock solutions, I don't know if you use them. We generally avoid them because there were some prominent cases in Massachusetts of creating very, very resistant bacteria with lock solution use. If you have catheter-related bacteremia, the interesting thing is, and I think as a nephrologist, we always have to try to advocate for our patients, and we think of the concept as preserving vascular access sites. It's well recognized that veins thrombose if you have a large dialysis tunneled catheter inside over a long period of time or repeatedly. So we lose access sites. So exchange of infected catheters over guide wires, with or without disruption of the fibrin sheath, can preserve venous access sites while effectively treating the infection. If you look at studies that compare the success of antibiotics plus guide wire exchange versus antibiotics plus removal and delayed reinsertion, you can see that they're by and large equivalent, independent of Staph aureus, enterococcus, fungus, whatever you look at. And that may in part be due to the fact that the fibrinous sheath that forms around the catheter may be a compartment that can harbor bacteria. So if you just pull out the catheter, the sheath remains, and anything that has grown on the catheter and has contaminated or has infected this stays inside that sheath, and that may actually lead to reinfection in the setting of removal of catheter and delayed reinsertion. You can treat these fibrinous sheath with balloon disruption. So you can see on the left, the image is the imprint of the catheter with the fibrinous sheath, and then you put a balloon in with a larger diameter, and then you can see the cephalic vein. The prevalence is universal. Sometimes they're thicker and sometimes thinner. Here's our lady with the purulent material. Her fibrinous sheath, you can see inside her fibrinous sheath these contrast-sparing things that if you aspirate them, and we try to do that if the patient is too unstable for disruption of sheath, you can aspirate purulent material out of the tract there. Catheter infections early on are typically due to procedural related issues after 30 days. They're entirely due to contact with hands, so staff, physicians. There is always a biofilm on the catheter within a couple of days. These are bacteria that do not cause disease, but these bacteria are then overgrown by pathogenic organisms prior to hematogenous spread and systemic signs of infection. You can have dynamic catheter dysfunction. You can see here a left-sided catheter that is looks like it's in a good position, but within weeks it doesn't work well, and that's because this is a patient with a lot of mobile chest tissue, and once the patient came from the reclined position, the catheter pulled down. The catheter is only fixed in the cuff position. Wherever the cuff goes, if the cuff goes down 4 inches, the tip goes up 4 inches, and then especially on the left side hangs up. So short tunnels are beneficial to prevent this effect of of dynamic catheter dysfunction. So if you think of compartments for a catheter, this is a very helpful schematic. You have the cuff that separates the outside that's colonized from the sterile inside. The tunnel is a space that if it's infected, you need to go to another side. You have the inside of the catheter, inside the blood vessel, that is covered by a fibrinous sheath that has its own effects on infections and function of the catheter. And then in some cases, you may have thrombus that is large. A lot of catheters have thrombus sitting on the side, over 25%, but in most cases, it does not have any clinical relevance. The last image I want to send you out with is that if you have a patient where a catheter was placed, see where the tip is. So here you have a plain chest X-ray, and you can see the tip of the catheter up there, while the target zone for the catheter is about 5 to 7 centimeters distal to the carina that is easily recognizable there. So what happens when you have a catheter tip there? Well, this is basically what happens when you put flow through a catheter on the machine. You see a split tip catheter that's run in standard configuration. You can see with a color dye how the sides of the catheter move to the vessel wall and can affect injury, while symmetric tip catheters do not move. They're pretty stable. If you do a split tip reverse, you get a ton of recirculation, and you get this blue dye in between the two catheters, and that's where usually a thrombus forms and then gets into the side holes. So this gentleman with the catheter tip up high in the brachiocephalic vein, this is how he presents once the fistula is on his right arm. Exactly corresponding to the catheter tips, the vein has shriveled up. Yeah? So this is the concept of catheter contact time. If you leave them in for a long time, you get an effect on the vessel wall, and in some patients, this is what you get. Other patients are fine for 10 years with catheters. We all know one of those, but that's not the general message. Good. So, summary. Dialysis access dysfunction is chronic. It always comes back. You just have to wait long enough. A good physical exam can be extremely helpful in guiding interventions, timing of interventions, and when to come back. If you do regular exams, you can say, yes, now it's dysfunctional enough that we have to do something. There is continuous remodeling in the access, and access pressures are drivers of dysfunction that limit access survival. And so we should aim with our visions to both regulate flow so that we can get good dialysis, but also that we limit pressures so that we don't get aneurysm formation and preserve skin integrity. Thank you very much for your attention.